In this session, we'll be dealing with the development of the midgut, especially the midgut rotation and hindgut. So you can see this is the 6 weeks embryo where you can see the midgut is starting to enlarge around the axis found by the superior mesenteric artery. Here you can see the celiac artery, which is the main artery of the foregut. Here you can see the inferior mesenteric artery, which is the main artery of the hindgut, and this is the superior mesenteric artery, which is the main artery of the midgut. You can see the midgut is started to elongate and trying to herniate through the umbilicus. The physiological herniation is beginning here. So here you can see the primary intestinal loop, which is formed around the superior mesenteric artery. So this is before rotation. You can see it in the vertical axis. If you observe, this is the pre-arterial segment. This is the post-arterial segment. Pre-arterial segment is cranial to the superior mesenteric artery, and post-arterial segment is caudal to the superior mesenteric artery. So if you observe, this pre-arterial segment will give rise to the distal part of the duodenum, jejunum, and major part of the ileum. And the post-arterial segment will give rise to the terminal part of the ileum. Here you can see the cecal bud, cecum, ascending colon, and hepatic flexure and transverse colon after the junction of right 2/3 and left 1/3. So before rotation, you can observe the pre-arterial segment is cranial, the post-arterial segment is caudal, and superior mesenteric artery is acting as a axis. This is the primary intestinal loop. Then what happens? There will be first 90 degrees of rotation counterclockwise when we are seeing from the ventral aspect. Okay, when we are seeing from the ventral or anterior aspect, there will be 90 degrees counterclockwise rotation, so that the pre-arterial segment will come to the right side and the post-arterial segment will come to the left side. Pre-arterial segment will go to the right side and post-arterial segment will go to the left side. That means the pre-arterial segment, which was cranial to the superior mesenteric artery, now it becomes to the right side of the superior mesenteric artery, and the post-arterial segment, which was caudal to the superior mesenteric artery, will become to the left of the superior mesenteric artery. Okay, this is the first 90 degrees counterclockwise rotation. Then what happens? You can see it is approximately 8 weeks embryo. So there occurred around remaining 180 degrees of rotation. That means total midgut rotation is 270 degrees. So initially we have seen 90 degrees counterclockwise rotation. Now here 190 degrees, remaining 180 degrees counterclockwise rotation is occurring. The first part to enter back after physiological herniation into the abdominal cavity is the jejunal loops, which will go to the left side. And the last part to enter will be the cecum. Which will go to the right side. So first part to enter back into the abdominal cavity is the jejunal loops, and the last part to enter the abdominal cavity after completion of physiological herniation is the cecum, which will go to the right side. You can see here the jejunal loops have entered back into the abdominal cavity and they occupied the left side, and the cecum has occupied the right upper quadrant of the abdomen below the right lobe of liver. Okay, so now what has made the intestinal loops to undergo physiological herniation? So what are the factors? First thing, rapid growth of size of the liver and also rapid elongation of the midgut. These are the two factors which are causing the physiological herniation of the midgut loop. Now, what are the reverse factors which are helping in re-entry of the midgut loop back into the abdominal cavity. That is reduced growth of the liver, and increased abdominal size. These are the two factors which are helping in re-entry of the midgut loop back into the abdominal cavity. Now you can see here the first part to enter back was the jejunal loops, which went behind the superior mesenteric artery, and the last part to enter was the cecum, which has reached the right upper quadrant of the abdomen below the right lobe of liver. Then gradually the cecum will elongate, reaches the final position in the right iliac fossa, resulting in the formation of the ascending colon, hepatic flexure, and you can see this is the transverse colon up to the junction of right 2/3. This will be formed by the midgut. And here you can see the duodenum is behind the superior mesenteric artery, whereas the transverse colon is anterior to the superior mesenteric artery. This is the normal position. And while this entire process of physiological herniation is happening, you can see at this particular part there will be a superior retention band, and here there will be an inferior retention band. The superior retention band in adults is represented by suspensory ligaments of Treats, that is the suspensory ligament of duodenum. And here the inferior retention band is represented by the phrenicocholic ligament. So now whatever the loops which has gone out have re-entered back. So total midgut rotation is 120 degrees. Initially there will be 90 degrees counterclockwise. Then after that, while the loops are entering back into the abdomen, there will be remaining 180 degrees counterclockwise rotation, so that the jejunum and ileum will go to the left side and the cecum will go to the right side, and the transverse colon will be anterior to the superior mesenteric artery, whereas duodenum will be posterior to the superior mesenteric artery. This is the normal position. So cecum is the last part to enter, and it will reach the right upper quadrant, then it will gradually elongate, resulting in the formation of the ascending colon. So this completes the development of the midgut. So now here you can see the development of cecum and appendix. You can see here this is the cecal bud which started developing in the post-arterial segment. So here you can see the growing cecal bud, and there is unequal growth. The right side grows more and the left side grows less, pushing the appendix which was present at the distal part of the cecal bud going more towards the left side, just below the ileocecal junction. So the distal part of the cecal bud forms the appendix and the proximal part forms the cecum. That in the development of cecum also, the right part of the cecal bud grows more and the left part grows less. So these are the different developmental positions with respect to the appendix. You can see this is the promontoric type, this is the pelvic type, this is the inguinal type, this is the subcecal type, this is the retrocecal position. So these are the splenic types, pre-ileal and post-ileal. This will be the paracolic. So you can see here, this is the normal position of the loops. This is with greater omentum, this is without greater omentum. So if you see the abnormalities of midgut, so you can see this is the omphalocele. This is mainly due to failure of re-entry of the herniated midgut loops. Okay, and clearly you can see these loops are covered by the amnion. And if you observe here clearly, you can see this is the omphalocele. O stands for omphalocele. And here you can see the gastrochassis, where there is a defect in the anterior abdominal wall. So earlier in the omphalocele there was no defect in the anterior abdominal wall. It was failure of re-entry of the gut loop. But here there is a defect in the anterior abdominal wall, and the abdominal contents are protruding out. Here it is not covered by the amnion. Okay, here you can see the gastrochassis, not covered by the amnion, no round contour. So now you can see this is the vital line duct. If you observe here, while we are seeing the midgut is connected to the umbilical vesicle through the vital intestinal duct. So this particular duct, when it is persistent, it will form the Meckel's diverticulum, and it will result in further anomalies. So location of Meckel's diverticulum will be approximately 60 centimeters from the ileocecal junction. It's 2 feet. So if you observe here, this is the persistent Meckel's diverticulum. So with the vital line ligament connected to the umbilicus. So if proximal and distal parts are obliterated and the middle part persists, becomes the intracystoma. This is the vitelline cyst. And here if entire mucous diverticulum is intact, its tract is intact, then it forms vitelline fistula or fecal fistula at the umbilicus. So sometimes here it will also form raspberry tumor. So now you can see the abnormalities of gut rotation. So if there is only 90 degrees rotation, so then what happens? There is failure of the last 180 degrees rotation to occur. So then the jejunal loops will become on the right side and the cecum will become on the, and the large intestine will become on the left side. And if there is initial 90 degrees reverse rotation, you can clearly see here the transverse colon, which was supposed to be anterior to duodenum, has become posterior and duodenum becomes anterior. So this is because reverse first 90 degrees rotation. So this is only 90 degrees rotation and last 180 degrees has never occurred. But here it is reverse of first 90 degrees rotation and remaining 180 degrees has occurred normally. So this is like atresia of the intestines. So one of the well-known one is the apple peel atresia. You can see the atrophied bowel loops around the vascular pedicle. So most commonly occurs in the jejunum, accounts for 10% of bowel atresia. So the affected portion of the bowel is coiled around the remnant of the mesentery. So this is the mesenteric remnant. So you can see the most common atresia. So there is a segment of the intestine is lost. Segment of the intestine is lost. And here there is a complete atresia. Segment of intestine is present, but it is like fibrous cord. So here you can see there is an underdeveloped area and a well-developed area separated by a thin diaphragm. Thin diaphragm. Okay. So here you can see without diaphragm. So this is the underdeveloped part, this is the properly developed part, and there is no separation. So this is representing the stenosis. So all these three will represent the atresia, because in some or the other way there is a complete blockage, but here there is just narrowing. So now development of hindgut. So hindgut results in the formation of left one third of the transverse colon, descending colon, sigmoid colon, rectum and anal canal. So here you can see the allantois, and here you can see the urorectal septum. So attachment of the allantois. You can see here. So attachment of the allantois divides the hindgut into pre-allantoic part and post-allantoic part. The post-allantoic part of the hindgut is called as cloaca. Post-allantoic part of the hindgut is called cloaca. So pre-allantoic part will give rise to left one third of the transverse colon, descending colon, sigmoid colon, and part of the rectum above the third Houston wall. Okay. So the cloaca will give rise to the rectum below the third Houston wall and up to the pectinate line of the anal canal, whereas the lowermost part of the anal canal below the pectinate line is formed by the proctodium, that is the anal pit. Now we'll go back. So we'll be concentrating mostly on the post-allantoic part, that is the cloaca. You can see there is development of the urorectal septum, which will divide the cloaca into an anterior primitive urogenital sinus and a posterior primitive rectum or primitive anal canal or anorectal canal. You can see this is the urorectal septum. So this is the cloacal membrane. So once the urorectal septum touches the cloacal membrane, so this particular part of the cloacal membrane will form the perineal body, and the area anterior to it will form the urogenital membrane, and the area posterior to it will form the anal membrane. So anal membrane will rupture at around 9th week, exposing the rectum and anal canal to the exterior. So this will be the rupture of the urogenital membrane, exposing the urogenital sinus. So post-Atlantic part of the hindgut is called cloaca, divided by urorectal septum into anterior primitive urogenital sinus and posterior primitive rectum or primitive anorectal canal. So urorectal septum grows down and also divides the cloacal membrane into anterior urogenital membrane and posterior anal membrane. And the point where the urorectal septum touches the cloacal membrane forms the perineal body. So the posterior primitive rectum forms the rectum and anal canal up to the pectinate line. So now, if there is failure of proper formation of the urorectal septum, it will result in multiple anomalies where here you can see the rectum connected to urethra, rectourethral fistula or urorectal fistula, and sometimes it might be rectovesical fistula, high fistula, and here you can see the rectovaginal fistula, and here you can see the rectoperineal fistula, and here you can see the imperforate anus, anal membrane failed to rupture. So these are the few anomalies of the hindgut. Thank you. So what is not started today is never finished tomorrow.